The topic for today's presentation is PTMC with VENO-ARTERIAL rail method. I am Dr. Muhammad Ishaq Khan from Peshawar Institute of Cardiology.
Dr. Ishaq, can you please turn on your camera?
Yes, sir.
Yes,
our patient was a 42 years old female with a history of severe rheumatic mitral stenosis and minimal MR. She presented with shortness of breath of NYHA class 3. She was in sinus rhythm. Her ECG shows sinus rhythm with findings persistent with pulmonary hypertension. The pre-procedural echocardiogram showed severe mitral stenosis with mean gradient of 19 millimeters of mercury, but surprisingly only mildly dilated left atrial diameter with severe tricuspid regurgitation and no LA or left atrial appendage clots. Her Wilkins score was 8, so she was planned for PTMC. Routine right femoral route was taken. After crossing the interatrial septum, the Inouye balloon was tried to negotiate through the mitral valve but failed, most likely due to the very tight stenosis. So after struggling with the balloon for some time, we decided to try the septostomy a bit higher to better help negotiate the balloon. But that didn't help either. So then a supportive implants wire was taken, and that was tried to offer a better support, but we also failed over there. So then it was decided to look for other options. While the literature offers different methods, that loop method, we did try the loop method, but it is usually successful when we have an enlarged left atrium. In our case, it was only mildly enlarged, so we couldn't do that. Another method is balloon flotation catheter, in which Van Gans catheter is used to cross the tight mitral valve. Pre-dilatation with peripheral angioplasty balloons are also used. In the end, we opted for the rail or loop method. For the VENO-ARTERIAL rail method, we took a GR catheter through the Mullen sheath into the left atrium, which guided an exchange length Terumo wire, which crossed through the mitral valve into the left ventricle, and then through the aortic valve to the aorta. And then the balloon was tried to negotiate. So as you can see, every time the balloon was pushed, the wire would come down. And we were not able to cross the balloon with this technique as well. So it was then decided to further push down the wire into the descending aorta and snare it there. Here you can see the wire being snared in the descending aorta. Although it was snared, but it was kept lax. This is the final position of the legs to remove wire, all the way from the left atrium into the descending aorta. Then the balloon was, we were able to cross the balloon through the mitral valve. Here you can see the final dilatation of the balloon with excellent results with almost no waste left in the balloon. After the dilatation, the mean pressure gradient dropped down to 4 millimeters of mercury. The patient was shifted with stable hemodynamics into the CCU, and later on, the mitral valve area through transthoracic echo was 1.8, almost 1.8 centimeters square with pressure uptime of 125 milliseconds and only mild MR. The take-home message is that in a difficult to cross mitral valve during mitral balloon commissurotomy, the VENO-ARTERIAL rail or loop method can be used easily for a successful procedure. I thank you all.
Ishaq, please be with us for the next 15 minutes. Don't leave, okay?
Right, sir. Okay, sir.
So this was an interesting case in which a snare was being used to hold the wire. And there are certain case reports have been mentioned, 2 or 3 in India, in Indian Heart Journal. So In such cases, different methodology was being used for doing PTMC with the VENO balloon. What we used to do is we switched to multi-track balloon catheter in such cases. So I want to have an opinion from the panels. Or
what is the risk of damaging the left ventricle, some cheesecake type of effect when you use this VENO-ARTERIAL rail? Because that's usually when you use, these 0.35
with the VENO
wires.
technique is very less.
No, when you do a VENO-ARTERIAL, where they pull the wire out.
The wire has been snared from the arterial side, has been pulled down.
So now the whole left ventricle
and they pushed the inner balloon.
No, I understand. But when you do this wire and you snare it out, the whole anatomy of...
Not snare it out, they just snare it and just tag it inside.
So you have, but it's still...
Okay, I will just have a comment especially on this. This was done in our institute. So the question that sir is asking, this is the very valid question. Sir, there is almost always chance of the Swiss cheese effect, but we have to lex the wire from the arterial side. Whenever we have crossed the mitral wall and it was just crossing the LV to the aorta and then snare through the femoral artery, then while passing the balloon, and we have to make sure, especially by doing frequently the transthoracic echo, just to see that where our wire is the in same position or not. The important thing here, and whenever we are going to cross the mitral veil and whenever we are going to balloon, we have to lex the wire from the arterial side. The important issue here, ideally, the wire should be removed. Ideally, the wire should be removed and the normal base to apex of the mitral veil balloon should be achieved, because the normal conventional base to apex position is the best for the NOA just to prevent the MR, etc. But we have tried so much time, especially with this lady, that we were afraid if we have some mishap and we were not able to keep the wire there, we may lose the balloon. So that is why we have keep the wire in the descending aorta snare, but just legs whenever we have inflated. There is definitely chance of the MR there, but in the interior mitral leaflet perforation, but fortunately that was...
Why I say this is when you are inflating the balloon, normally the NOA, you know how it points.
Yeah.
But look at where it was pointing and look at the anatomy of how the wire was going. So this is a very important point to remember, that we do it in other cases as well, for pulmonaries and others. You need to be very careful.
Yes, sir. Especially the mitral regurg and interior mitral perforation risk is almost always there. Wow. And the important thing, you have to relax that wire just to keep that complication to the minimum.
Shazib, when you have crossed and you have an extra support wire, the extra support wire, if you relax or otherwise, it won't behave as a floppy wire. So it's very dangerous that you use this, so, number one. Number two thing, why don't you have used a 12 millimeter PS balloon to pre-dilate you have the extra support wire, you have pre-dilated the ostium of the mitral valve, and then you go with your regular NOA balloon technique.
Yes, this is a very valid question, sir. I agree with you, especially when we are using the support wire, the implants. We have tried first, we have crossed this mitral veil with the implants, the support wire, but even with the support wire, we were unable to cross the balloon. So when we were just snaring this, so we have just used this styromo. That was not just the gliding wire, not the super support wire. So the other thing you have mentioned, we were first discussing that option that we have to pass the peripheral balloon and we have just prepared that. But ultimately, we have decided it may not work. If we are going to negotiate just passing through the septal, the intra-atrial septum and then through the mitral, it may not occur. But definitely that was our mind, and first we were discussing that option. So that was...
Shazib, it was a nice case and nicely done. But I have query, we are using this balloon, but unfortunately, you are saying that you have tried this balloon on extra support wire.
Yes, sir.
But lumen of this balloon is very narrow. How that extra support wire got room